jump right in. Can all you virtual people see just my big slide?
Yes.
Okay, all right, so we're gonna get started. Okay, so we won't worry about points since we're doing popcorn style. And you don't have to answer in a question format. I'll still give you credit. Yeah, I had to lay out some ground rules because there's been some knockdown, drag out arguments in the past when I've done Jeopardy. All right, so here are our categories. Today we're doing rhythm emergencies / urgencies. So our categories, boom, boom, pow is going to be fast rhythm, so tachycardias. Slow motion for me is going to be bradycardias. Killing me softly is just worrisome EKG findings that could kill you. Jagged little pill is going to be medication questions. And then MmmmBop is pacemaker questions. So we'll just go across the top and do all the 200s and the 400s, 600s, 800s. So get excited. This is so fun. Okay. So first question, a previously healthy 3-month-old male presents to the ED with fussiness. His heart rate is 280, respiratory rate's 50, blood pressure is 80/45, cap refill is less than 2 seconds. He's warm and well perfused and he is alert. What is your diagnosis based on this EKG and those descriptions? And what is your first line of treatment? Saw you first. All right. Good. So correct, this is SVT. So what tells us it's SVT? Yeah. So it's in the rate, it's greater than 220. There's no P waves. It's a narrow QRS and it's a fixed rate. So there's no variation. So you're correct. In a stable baby like this, I gave you all the descriptions to tell you this baby was nice and stable. Your first line of treatment is going to be your vagal maneuvers. Obviously, while you're doing that, you're going to be asking your nurse to get an IV because you're always thinking about the next step. So in a baby, ice to the face is going to be your best bet for vagal maneuver. And ice to the face is really pretty dramatic. So you need a big like biohazard bag of ice water. And you want to submerge as much of the face as possible without covering the airway technically if you're following PALS, although that makes it work better if you cover the airway. Other things you can do is try a rectal temperature. You can gag the baby with a tongue depressor. If it's an older kid, like a toddler, you can have them blow on a pinwheel or blow into a balloon. And then older kids have them bear down or do crunches or anything that increases their abdominal pressure. But only do these things if they're stable. And then second line is going to be adenosine. And then if the patient is unstable, so if I was giving you any indication of poor cardiac output, so I told you the kid was mottled or their extremities were cool or they were lethargic, or I gave you hypotension, then you would consider synchronized cardioversion for your first line. Questions about that? We see SVT a lot and we haven't had a lot lately, so just be prepared. All right, so bradycardia for 200. So 8-year-old male with trisomy 21 presents with fatigue. What is this rhythm and name one potential cause? What you got? Yep. Yeah. Yeah, so that was the tip for this one, was trisomy 21 and fatigue. So he probably has hypothyroidism. But just thinking through other causes of sinus bradycardia that you should always think through when you have a patient who's bradycardic, especially if they're symptomatic. Think about hypothyroidism, think about electrolyte derangement, and then a big one in the hospital is increased ICP, and then hypothermia can also cause bradycardia. And then just a little recap for quickly counting the rate is I usually use the big box method just so I can eyeball the rate really quick. So one box is 300, 150, 100, 75, 60, 50, 43, 38. All right, killing me softly. So these are going to be like dangerous EKG findings. So 12-year-old male with a history of syncope. This is his EKG. And what is your diagnosis? Good. Exactly. So long QT syndrome. So you see the end of the T wave falls past half the distance of the RR interval. So that's a good kind of eyeball method to tell you that QT is long. But yeah, this kid has long QT syndrome. So medication wise, we treat these with, or we prophylax them with beta blockers. We do recommend genetic testing so we can know which type of long QT because we do manage them a little bit differently. It's typically autosomal dominant, so all first degree family members should get screening. And then we consider ICD placement if the child has ever had concerns for a possible sudden cardiac arrest. Yeah, that's really the only reason we do ICD. Questions about that one?
Would prior history of syncope necessarily qualify as?
So when we hear about syncope in a long QT, that's what we presume probably happened. So oftentimes we will do an ICD if they've had long QT and syncope. So this kid would probably get an ICD. All right, a 6-month-old, 8-kilogram male is intubated for respiratory failure. He has persistent sinus bradycardia of 44 beats per minute following ET tube suctioning. His blood pressure is 60/40. What med do you give and what dose? So he has a pulse. You're not doing CPR or anything like that. He's just bradycardic.
Atropine.
Good. What's your dose?
Is it 0.01 mg per kg?
Close. When do you give 0.01 mg per kg?
Is that the vagal dose?
That's if you're giving it like prophylactically, like before you intubate. If you have symptomatic bradycardia, good, 0.02. So this kid would get 0.16 milligrams. 0.02 mg per kg is the dose for symptomatic bradycardia that we think may be of vagal origin, which is why I was telling you it happened with ET tube suctioning. The minimum dose for atropine is 0.1 milligrams, and they changed the max dose. It used to be 1 milligram when I was a resident, but now it's 0.5. I don't know what's on y'all's cards. Is it 0.5 for your max dose? I won't tell Dr. Ricker that y'all didn't know that. Okay, I think for a dose like this, when you're not in a code situation, your max is 0.5. But yeah, so the 0.01 mg per kg is what you would give like if you're going to intubate a child and you want to give something to prevent vagal induced bradycardia. Okay, yeah, that's what I got it from PALS. So that's glad to hear y'all have up to date. All right, so remember this was the pacemaker category. So I'll give you a hint and tell you that this is a paced rhythm, but I want you to tell me if it's atrial paced or ventricular paced and why. Good. What makes you say that? Mm-hmm. Well, what do you think about the width of the QRS? It's wide. Yeah, so that's, if you see a normal P wave and you see a wide QRS with a pacemaker spike, that means it's a ventricular paced rhythm. And the way And why that happens is because when you're pacing the ventricle, you're not going through the bundle of His, which is what makes your QRS nice and narrow. So when it conducts outside of the bundle of His, that gives you a wide QRS. That's why ventricular tachycardia, VFib, all those are, and PVCs, that's why those are all wide complex QRS. So see pacing spikes, you see a good P wave, and then a wide QRS is going to be ventricular paced. And that's important to remember because patients who are ventricular paced are at risk for cardiomyopathy down the road, just because that the myocytes don't respond as well to pacing compared to normal atrial pacing. So you just have to keep an eye out for ventricular dysfunction. Good. All right, on to 400s. So 13-year-old presents to the ED with heart racing after 2 days of vomiting, diarrhea, and fever. His heart rate is 190, respiratory rate's 24, blood pressure is 82/42, cap refill is 3 seconds. He feels cool and clammy and he's disoriented. What is your diagnosis and first line of treatment? Good, you didn't fall for the trick here because I gave you a heart rate of 190. I wanted you to guess SVT, but you saw those P waves and you saw that history and you're like, this is shock. Yeah, so sinus tachycardia, secondary to volume depletion, shock, possible sepsis. So fluid bolus is going to be your first line of treatment. You can technically have some types of SVT where you see P waves. So always important to keep in mind that if it seems like it's shock and you give a bolus and it gets worse, then you start to think about the other kind of weird things, but that was the exact right answer. And so don't always assume SVT when the heart rate's over 180. So remember to get a history. So great job. All right, what is this? I'm hearing all of the things you could possibly guess.
That's second degree heart block.
Which type of second degree? Type 1 or 2?
1.
Wrong.
Dang.
Why is it type 2? Right, so we have a fixed PR interval and then we just get randomly dropped QRSs. So you see here, if we measured that with calipers, the PR would be consistent throughout. Whereas with type 1 or MmmmBop, we get progressive prolongation of the PR interval till we then drop a QRS. So this is MmmmBop's type 2 or second degree type 2. It's important to call cardiology for this one because oftentimes it can progress to even higher grade heart blocks and ultimately require a pacemaker. And so this block actually occurs below the AV node, and that's why the PR interval is fixed. But because of that, it's unpredictable, meaning they can jump to third degree heart block without any warning. So definitely important to follow these closely. It's unusual to just randomly see MmmmBop's type 2 in a healthy kid. So this you would think about like in a post-op, a kid who's had heart surgery in the past or has cardiomyopathy or something else unusual like that. So if it's yes and no. So if you're seeing this like in the first 7 days after surgery, usually it goes away. It's just like that area is kind of stunned. But if it's a kid who had surgery like a year ago or months ago, it's probably not going to go away. All right, so 8-year-old male with family history of sudden cardiac death. Screening EKG is done by his pediatrician. What is the diagnosis and what is important for this patient to avoid? I'll give you a hint. This is what the ER thinks that everybody has who gets an EKG. Yeah, so what tells you it's Brugada? We see PVCs in non-Brugada 2. So look in V1 and V2. Yeah, so you get, it looks like a right bundle branch block plus ST elevation. So type 1 is technically the only diagnostic EKG that you can say, yes, this kid has Brugada syndrome. And so you have to have an ST elevation of at least 2 millimeters, a downsloping ST segment, and an inverted T wave. So this will be described as like a coved type ST elevation. And you have an RSR prime, so a bundle branch block. And then type 2 looks like a saddle. So if you think about like a horse's saddle, like somebody could sit in the middle of that. That's also worrisome for Brugada syndrome. So definitely call cardiology if you have concerns for Brugada syndrome. Typically, these patients will often get an ICD. They need genetic testing. First degree relatives need to get tested because it's autosomal dominant. And then the big thing is these patients have to avoid fever because for whatever reason, fever can trigger arrhythmia in patients with Brugada syndrome. So if we're ever like unsure if somebody has Brugada, because there are definitely some EKGs that are borderline, and if you get genetic testing and it's normal, and we'll also do procainamide testing in these patients, and if that's normal, I'll usually just tell them in an abundance of caution, if you have fever, aggressively treat it. And then they obviously can't do competitive sports. Well, usually they don't get diagnosed until teenage, like adolescence or like young adulthood. Usually we'll present with syncope. Yeah, or sudden death, like aborted sudden death. So it's scary. I mean, it's a big deal. That's why the ER wants to always rule it out on EKGs. So. All right, 3-year-old, 15-kilogram male presents with the above rhythm. What med do you give? What is your starting dose, and how do you give it? Okay. You have cards. You can use your cards. Oh. Maybe you could phone a friend. Yep. What's your max first dose? Yeah. What's your max second dose? Good. And how do you give it? Yep. Rapid push. Okay, good. So adenosine for this kid who is 15 kilograms, we would give 1.5 milligrams because it's 0.1 mg per kg. There's no minimum dose, but your max first dose is milligrams. You're going to give by rapid IV push as close to the heart as possible. So really antecubital fossa and above. You want to have the nurse hook it up with a, what do you call those things? A stopcock, where you can have a flush on one side and the adenosine on the other, and essentially give the adenosine and flush almost simultaneously. Sometimes it helps, like if it's an arm, you can have the nurse hold the patient's arm up to help gravity get the medication to the heart faster. It just has a super short half-life. So the quicker you get it to the heart, the better it works. And it is inactivated by an enzyme on the surface of the red blood cells. So the other big thing is to make sure the nurse doesn't draw back into the adenosine syringe, like to check the IV. If she needs to pull back, have her pull back on your flush instead. But if you get blood into the adenosine syringe, you're already starting to inactivate it before you've even pushed it. Your second dose, you can give 0.2 mg per kg for a max of 12. It's technically contraindicated in WPW with AFib. We don't usually see AFib in kids. So the ER worries a lot about adenosine because of the risk of triggering ventricular fibrillation. But in children, we don't really see that. Caution in kids who have asthma because it can trigger a pretty profound bronchospasm. And then always have your defib pads on the patient or readily accessible, and have your crash cart ready to go. Because just like we talked about above, there is a risk of ventricular arrhythmia. There's also a risk of asystole. So when you give adenosine, you're blocking the AV node, you get a pretty profound pause usually, and everybody kind of holds their breath for a second. But in healthy kids with normal hearts, it usually starts right back up. But it is a little bit scary. So always have your code meds and equipment nearby. And then just one thing to keep in mind, it's controversial to give adenosine in transplant patients. It's typically not recommended just because the heart is denervated. So sometimes we'll try it like much smaller doses, but oftentimes we'll try something else, like maybe a slow beta blocker infusion. But just talk to cards first if you have a transplant patient who comes in with SVT. And then unless they're unstable, then you'd obviously cardiovert them. Okay, 13-year-old male with recently diagnosed hypertrophic cardiomyopathy after a cardiac arrest has undergone ICD placement. He presents to the ED with complaints of recurrent ICD fires every few seconds. You confirm he is stable and is in sinus rhythm. Cardiology recommends trying this. How do you do that? Yeah, good. So if you confirm he's in sinus rhythm and he's not truly in ventricular tachycardia and getting appropriately shocked, but he's truly in sinus rhythm, then you would try putting a magnet over it because that stops the firing. And then you need to call the agent of the company for his ICD so they can interrogate the ICD. And usually they can just tweak the sensitivity because it's probably a problem that it's oversensing. And so they can adjust that. What's that? Well, the ER, usually on the side of the code cart, there's a magnet stuck to it for this exact reason. Because we obviously don't want him to keep getting shocked because we could send him into an arrhythmia. So.
Stop it like that ICD is done.
No, it's just as long as the magnet's on the ICD, it'll keep it from firing. If you take it off, it kicks right back in. What was your question? It has to be a strong magnet. But if you're in an emergency situation, like if you're in the ER or the PICU, there should be a magnet available to you. You can definitely get one from the ED if you're like up in the PICU and they don't have one there. Like I don't think a refrigerator magnet would do it, you know. The other thing, not related to ICDs, but I've had patients who their pacemaker was also triggering their diaphragm. So it's like giving them constant hiccups. So, yeah. So their ICDs and pacemakers are super helpful, but they also, you know, they're going off of what they think is happening. And if you don't set your parameters correctly, it can really cause harm too. All right, so a 16-year-old male presents, you notice he has a midline sternotomy. You don't know his history because he fainted at school and he's brought in by EMS unconscious. When you hook him up, his heart rate is 280 on the monitor and his pulse is not palpable. What is your diagnosis and first line of treatment? Good. Good. What are you doing while you're getting things hooked up? Good. So this is ventricular tachycardia, specifically pulseless VTach. It's a wide complex tachycardia. The rate is regular. If they have a pulse and they're stable, you could consider consulting cardiology. If they're unstable, but they have a pulse, then we would synchronize cardiovert. If they're completely stable, then usually we'll choose a medication for this instead of giving them electricity. Sometimes after talking to cardiology, you'll give adenosine because sometimes SVT can look like this if they have a bundle branch block or it's aberrantly conducted. And so in a kid who's perfectly stable, who has great vital signs, who just has this wide complex tachycardia, we will sometimes consider trying adenosine in that situation. Otherwise, amiodarone or procainamide are your meds of choice. But this kid was pulseless, so CPR and then race to defibrillate. And what do y'all think he had? He had a midline sternotomy and presents with VTAC.
Yes.
Tetralogy of Fallot is the big thing we worry about with ventricular arrhythmias, or in tetralogy of Fallot post-op. Long-term, we worry about ventricular arrhythmias. Okay, so you were called by the PICU nurse that this rhythm was identified on your patient while sleeping. They are a 13-year-old male with DKA about to be transferred to the floor. What is your diagnosis? Good. So you can see, obviously, the PR interval gets longer until you have a missed QRS. So second degree type 1 or MmmmBop is typically benign, especially while sleeping. You can see it in situations where you have increased vagal tone. So this kid may have some increased ICP if he had DKA. We do recommend a 24-hour Holter in this situation just to make sure there's no higher grade heart blocks. And then the other thing to consider if the patient has no other reason for MmmmBop is to consider Lyme disease or rheumatic fever. So do a good history. But we'll see MmmmBop like in super healthy athletes just because they have so much vagal tone. And typically it's completely benign. All right, so name this abnormality on the EKG and list at least 3 acceptable treatments for this. Yeah. What's the first thing that I want you to give? Yeah. Yeah. So very obviously peaks T waves. So check the potassium. First off, from a rhythm protection standpoint, give calcium, and then your other things to actually lower the potassium. You can try albuterol, insulin, glucose, sodium bicarb, pixelate, Lasix, and ultimately dialysis if you can't clear it. All right, name one contraindication to using a beta blocker and name one side effect of using a beta blocker. And then what's one side effect? Like bad side effects. Have y'all ever started a beta blocker on a baby like for SVT? What do we usually have you do?
Hypoglycemia.
Good. Yeah, so we'll check a glucose before each feed. Okay, so beta blocker contraindications. The big one is significant asthma. And then higher than first degree AV block. Sometimes we still have to give it even in that situation, and then we just repeat the EKG to make sure it's okay. Side effects, like you said, hypoglycemia. So in infants, when we start beta blocker, bless you, I think, we'll check fasting glucoses for like the first day or so. The other thing obviously is bradycardia and hypotension. It can also decrease cardiac function. So in a patient that you're worried about function, you should be cautious with beta blockers. Can cause syncope and AV block. I just always like to recap or reiterate that we don't ever give IV bolus beta blockers to kids. Sometimes I'll have you start a drip for SVT that we can't get under control with adenosine, but we never bolus. So we would start a slow drip, but we would never bolus IV. And it's just because they can have such a profound cardiovascular collapse after beta blocker. So it can be fatal. So no IV beta blockers unless it's like a slow drip. And then just on another similar note, thinking about things that we don't do is don't ever give a calcium channel blocker to a neonate or an infant. They are super dependent on calcium for their myocyte contractility. So if you give a calcium channel blocker to a neonate or a baby, they can also have profound cardiovascular collapse. So no IV beta blocker bolus and no calcium channel blockers to neonates or infants. Questions about that? So the time that the IV bolus will come up, I've had a couple questions about this. So like if you have a kid that comes in on propranolol and they're NPO, don't give IV propranolol. We can usually still give the med PO, or we can do something else IV, but don't do IV propranolol in that setting. And then, or we could do, if they like really needed something IV, couldn't do anything enterally, we could do a drip in that situation. And then the other time it'll come up is in SVT that we can't get to go away with adenosine. Sometimes we'll start esmolol as a drip. And I think when you order it, there's the option of giving a bolus first. Don't ever give the bolus, just the drip. Okay, so we talked about what a magnet does to an ICD. So when you put a magnet on an ICD, it stops it from firing. What does it do to a pacemaker? It does something. It doesn't turn it off, but it does something. What's that? I think I heard somebody. It doesn't deactivate it. What? No, I'll just tell you. Okay, so it turns it into asynchronous mode. So it will now just pace on a set rhythm. It won't detect the underlying cardiac rhythm and pace accordingly. So this is important to remember because this is what we will do in the OR. Like if a patient's having surgery and they're going to use a Bovie, because the Bovie can trigger the pacemaker, or it can make the pacemaker think that the patient's having electrical activity and then it wouldn't pace and the patient would not get appropriate pacing. So in the OR, they'll do this just to prevent Bovie interfering with the pacemaker. And so asynchronous mode is just the pacemaker has a rhythm, a rate that it's set at, and it goes at that specific rate regardless of what the heart is doing. Whereas normally a pacemaker would work by letting the underlying electrical activity of the heart happen first, and then if it doesn't detect that, then it would pace. Does that make sense? So it's kind of like overdrive. Yep. Yep. Yes, that should be your response to this. Whoever said that. 12-year-old male is found unresponsive in a pool after swimming laps. EMS arrived and they obtained the following rhythm. He is pulseless. What is your diagnosis and treatment? Good. What else with CPR? Well, yes, defib. Good. So as torsades, your first priority is good CPR and time to defibrillation. You can give magnesium. That's one of the treatments for torsades, but don't delay defibrillation to get magnesium. You can do them at the same time, but definitely prioritize getting that child defibrillated. This child probably had long QT syndrome, especially if you have an event while swimming. That's a big trigger for long QT syndrome. And this child will need beta blockers and obviously will need an ICD since they had a sudden cardiac arrest. We don't know. There's a certain class of long QT syndrome that like we tell them not to swim because it's such a big trigger. It's probably related to something with holding your breath, but all right, a 3-year-old female is in status asthmaticus, a 3-year-old female in status asthmaticus arrest. She has undergone 3 rounds of CPR and epi. She remains pulseless, and this is your rhythm on the next pulse check. Diagnosis, and what do you do? Yep. What do you do? Yeah. So this is PEA. So I mean, it looks like a very organized rhythm. Like you feel like that should be something real, but she doesn't have a pulse. So keep in CPR and epi. It doesn't matter if you see a rhythm. No pulse means no perfusion. Remember, even if you see a rhythm, return on the monitor. Don't stop compressions to check because it may just be PEA. And every time you stop compressions outside of a pulse check, you're compromising coronary artery perfusion. So wait until your next pulse check. All right, so 14-year-old male with palpitations and syncope undergoes a stress test as part of his workup. And can't get it to, ooh. That's what the EKG looks like during his stress test. So what is his diagnosis? What do you see on here? You see PVCs, do they look the same or do they look different? They like some of them have a completely different axis. What do you call that when it's different morphologies? Polymorphic. I heard you say it. What is it? Say the whole name. And then what do you put at the beginning of it? Before that. Okay. So what is your close? What is stress? What does your body release when you are stressed? Yes. Good. There you go. Group effort. So anytime you see multiple morphologies of PVCs on a stress test or on a Holter or EKG, we have to worry about CPVT. And this is a rare, but is a cause of sudden cardiac arrest in athletes. So PVCs and ventricular tachycardia are triggered by catecholamines. So obviously exercise is not a great idea for these kids. They're treated with beta blockers, sometimes flecainide, and then sometimes they'll get their sympathetic nerve transected to prevent that stimulation. ICDs in these patients are controversial because if you go into VT, then you get shocked by your ICD, then that causes more catecholamines to get released. And so you can go into what's called an ICD storm, where essentially it's like recurrently shocking you into a ventricular arrhythmia. So if you see multiple morphologies of PVCs on a patient, whether it's like in the ED on an EKG or wherever, it's important to think about this. And
Will you see this only on a stress EKG, or like they come in, they're totally fine, and you just like check an EKG? And would it look like anything abnormal?
so you may just see occasional PVCs with a different appearance to them. And so then they would need a stress test with precaution when you do the stress test, because you can trigger that. So that's the reason when we do stress tests, we keep the defibrillator in the room with us, because CPVT is a big one that when you're stressing the patient, you can trigger that arrhythmia. All right, 3-year-old male presents after getting into his baby sister's heart medicine. What is your treatment? Well, what do you think they got into? What do you see? Yeah, this is a little bradycardic. What about your ST segments? Your T waves look funny. Your QRSs are kind of wide. And you're having a PVC every other beat. What medication can do all sorts of weird things to your EKG? I think I heard somebody. Well, digoxin, good. So first of all, ABCs, if this patient is bradycardic, make sure their ABCs are okay, but then you can give the digoxin specific antibodies if you confirm that that's what medication they have at home. With digoxin ingestion, it's important to make sure you correct any electrolyte abnormalities. If they recently took it, you can try charcoal. if they're bradycardic and they're symptomatic bradycardia, you can do atropine. If they have ventricular tachycardia from the digoxin, you can give lidocaine. But you do want to avoid cardioversion because for whatever reason, it increases your risk of VFib. So digoxin is dangerous and we use it a lot. So just important to keep that in mind. And then last question. 10-year-old female with history of a pacemaker is admitted with respiratory distress. She is found unresponsive with no pulse. This is her rhythm. What is your treatment? Good. CPR and epi. So PALS is no different with a pacemaker on board. So if your patient does not have a pulse, you still do CPR, you still give epi just like you normally would. And then kind of thinking through, similar to PEA, even if the pacemaker is giving an electrical stimulus to trigger some electrical activity, if there's no pulse, there's no perfusion. So you still need to do CPR, even if you see a normal, what looks like a normal pacemaker rhythm on your tracings. So CPR and epi. Questions about that? Questions about any of these?
What is the easy way to remember when you would give synchronized versus not synchronized?
So unsynchronized cardioversion is defibrillation. So we really only do that when we're pulseless. Yeah, so pulseless VTAC and VFib is when we would defibrillate somebody. Whereas synchronized cardioversion, you would only do that if your patient had a pulse, but were unstable. So if it was unstable SVT, but they still have a pulse. If it's unstable VT, but they still have a pulse. We will also cardiovert atrial flutter in the neonates, and then atrial fibrillation. But the only time you defibrillate is when you don't have a pulse. Does that make sense? Just think, if you're doing CPR and you're using the machine, you're going to defibrillate. Any other questions? Yes. So you can give the digoxin antibodies. That's the treatment to actually clear it from their system. If they're bradycardic and they're symptomatic bradycardia, so hypotensive, poor cap refill, then you could give atropine. And then if they have ventricular tachycardia, then let's go back. We'll go through all these. Sorry. Yeah, I think it's lidocaine. Yeah, lidocaine. Like I don't want to say amiodarone and be wrong. Yes, lidocaine if VTAC. And then avoid cardioversion. Any question?
That kid in the picture who had MISC, who had the monkey bug,
Yes.
what happened with that?
She had a Holter and had winky block, like it looked like during probably sleeping times, and then would just have first degree AV block the other times. But her overall heart rate range and average was normal, so we just watch in that setting. And winky block has a low risk of progressing to the higher grade heart block, so we usually just keep an eye on it. And the only, even if we have higher grade, like second degree type 2 or third degree heart block, even then we don't always do a pacemaker unless they have bradycardia, like symptomatic bradycardia, or the rate is low enough to indicate a pacemaker. So we try to avoid pacemakers as long as possible in kids. But if they're symptomatic and they need it, that's the next step. But she should, once she gets out of her acute illness, should be fine. That's a great question. So PVCs are kind of complicated, but if you're getting up to the 20% range of PVCs, that's when we can start to see ventricular dysfunction from it. So often then in that situation, we would start a beta blocker to try to suppress some of the ventricular arrhythmia. And then I've had some patients who've had like 30% PVCs and have not had any problems with their, and then eventually, usually they just kind of burn out over time. But if it persists, then you start a beta blocker then too. Sometimes we have to ablate them if they're having a bunch of PVCs and either they can't tolerate a beta blocker or it doesn't work for suppressing the PVCs. Sometimes we'll have them ablated. But if you think like 20% and below, the risk of cardiac dysfunction is pretty low. But once you get up to 20% or higher, it's something you worry about. And then the other thing is, so kids with frequent PVCs will do a Holter to make sure, because sometimes they'll have like ventricular tachycardia or an accelerated ventricular rhythm. So in that setting, you'd be more inclined to either ablate or start a medication. And then if it's not fast, so, you know, if you have 3 PVCs in a row and the rate's like 100, we call that just an accelerated ventricular rhythm. And usually depends, like we'll often start a beta blocker for that, but sometimes we can just watch that. All right. Welcome.